Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Welcome to this week's episode. With you, your co-host, Dr. Herb Bravo, and your co-host, Dr. George Rogel. Help us welcome Dr. Susan Sirota, who is a teacher, a leader, and of course a pediatrician. Dr. Sirota is one of the founding partners of Pediatric Partners and a chairperson of the Board of Managers of PediaTrust. She's been proudly caring for children in and around Highland Park and Vernon Hills in the suburbs of Chicago for the past 25 years. Hi, George. Welcome from Italy. The background is gorgeous.
Yeah, this is a special episode. We're in 3 time zones. You're in Washington, right? Virginia.
That's correct.
I'm in Italy and Dr. Sirota is in Chicago. Let's see if the technology actually can get through and work without breaking. Let's find out.
How are you,
Dr. Sirota? We could not let this podcast go without with Dr. Sirota. She's a special person, so I had to be here.
How are you, Dr. Sirota? Thank you for sharing your time with us today.
Oh, thank you. I'm doing great. And I really appreciate the opportunity to join both of you and George for making time.
We always start by asking, why did you become a pediatrician?
Yeah, that's probably an easy question for me. I mean, the answer is that from as far back as I can remember, I think I wanted to be a pediatrician. It's just something I always wanted to do. I'm not even sure I ever considered doing anything else. If you ask my mom, she would say that somewhere around preschool age, I told her that I had a pediatrician who we really liked, and I told her that that's what I wanted to do. I wanted to be what he was. And I really stuck with that. I think organic chemistry, like a lot of us in college, maybe just question that briefly, but this was my long-term plan.
Oh, wow. What, did you grow up in a large town or small town?
So I grew up in a suburb of Chicago, so just outside a very large city, and I have no physicians in my family. I am the only physician.
Oh, wow. For those of our listeners who don't know, what is PediaTrust?
So PediaTrust is really just a large pediatric practice. So, early on when we were forming, the term super group was used, or group practice without walls. I think of those as synonymous. And another way of thinking about PediaTrust is we're really just a merger of what were 12 independent pediatric practices, and we came together under one tax ID. We like to talk about getting bigger so that we could stay small. So we all had the identity of our legacy practices. We were practicing in the Chicago area where there was very rapid consolidation of healthcare going on at the time. This formation came about, and it was a way for us to continue to do what we love doing, which was high quality pediatric care, but in our own smaller independent settings.
And how many pediatricians do you have in the group?
So we've grown, as I mentioned. We're currently a merger of what were 12 legacy practices. We started with 7, and our numbers fluctuate a little bit because especially this time of year, we have both hirings and retirings, but we are between 75 and 80 pediatric clinicians. We are almost all pediatricians. We do have a handful of pediatric nurse practitioners who work with us as well.
And then
Listen, tell me, getting doctors together to work together is difficult. It's like herding cats, some would say. That was some challenge.
Yeah, it was. We had, I like to think of our start as having a bit of a head start. So there are 7 original practices, and those of us that all came together for this steering committee process, which we went through for a whole year when we were forming, we were all members of the same pediatric IPA that was launched out of our children's hospital, Lurie Children's in Chicago. So we were coming together as members already of a messenger model IPA. And so we were starting off with similar contracts, similar approaches. And so that gave us a bit of a head start. But governance is very important, and we were very mindful and I would say deliberate about how we built our governance structure. And I think that's been really instrumental versus figuring it out after the fact.
And you also have 2 after-hour centers.
Yeah, I mean, technically we have 3. 2 of them are open Sundays primarily. But yes, that was one of our early initiatives, was to have our after-hours immediate care, so that 365 days a year, there was always somewhere our patients could go to see pediatricians and PediaTrust when our offices were closed.
So they're primarily open on Sundays?
Well, so we have our largest one is open every day, 365 days a year, but Sunday's a very high demand day. So most of us have evening hours, most of us have Saturday hours, but not Sundays and holidays. So Sundays we have 3 locations, just because as we've grown, we've spread across the geography, and it's much more convenient for patients.
And the after-hour centers,
Do all doctors work the urgent care? Do all the doctors work the urgent care, or do you have special people that do the urgent care only?
So it was interesting when we started, it was very early on, the initiative, and it was summer. And there was a lot of debate about, is this the wrong time to launch? Where there aren't sick visits. Obviously that was pre-COVID, we're drowning in sick visits now. But when we started, we said, look, there were 30 owners at the time, there's 30 days in most months. If everybody takes 1 day a month, we're going to be able to cover this. At this point, we have a number of physicians who do work because we pay our owners for their time spent working. We also have some physicians who are employed specifically to work our after hours. And then we have employed physicians within PediaTrust who also choose to work those hours just for additional pay.
And the hours for the after hours are just evening hours, or?
So during the weekday, because our offices are all open Monday through Friday, and most of us have some evening hours. During the evenings, we're open now 6 to 9. It used to be 6 to 10. We shortened those hours in COVID, and at this point, we don't have plans to go back to 10 o'clock. Most of the other urgent cares in the Chicago area close at 8 o'clock anyway, so we're open beyond that time. And then on Saturdays, because some offices have just half-day hours and not full-day hours, we open from 1 to 5 on Saturdays, and then 9 to 1 on Sundays and holidays.
All right. And you also have incorporated behavioral care. I don't know if all the legacy practices or some of the legacy practices too.
Yeah, so the way it works is we partnered with a group that's called Pediatric Primary Care, Psychological Associates, but PCPA they go by. And their model is that they integrate their psychologists right into independent practices or other practices, in our case, independent practice. And we don't mandate that every PediaTrust location have integrated psychologists. It's a choice, and many of us choose to have. But what happened in the pandemic, and then the nice thing is the risk doesn't lie with us, the financial risk, because as you guys know, mental health and behavioral health billing is very different, and some of the codes. And so they're responsible for their scheduling, they're responsible for their billing. We co-hire, so when we're hiring someone for a location, we co-hire, and then they are integrated right into our office. They're available to us in person or virtually, and we all work in the same electronic health record. So the care is very much integrated, but there is a financial piece and billing piece that's not integrated. And then because we went to primarily virtual care for mental health care in the pandemic, that has continued. And our patients choose whether they want to access a psychologist in person or virtually, but they're accessible to everyone in PediaTrust, because even though we have several different locations, many of our locations are very close together in similar communities. So it's not too far for a patient to travel who chooses in person.
That's wonderful, because everybody worries about the expense of a psychologist and managing that. Here in Virginia, psychologists are like dentists. They don't take health plans because they can demand $250 an hour cash, and they'll never get that kind of reimbursement from insurance.
Right, and our arrangement was that these psychologists would be on all of the insurance plans that we're on, including they're able to see our HMO patients. So it's just this sort of win-win model that as I was searching out what we were going to be doing in PediaTrust, that we were able to find in our geography. And it's been excellent, and I can't recommend it enough. It was saving us before, and you probably know this, but for patients, if you just say to them, I think you should go see the psychologist in a visit, and you give them a recommendation, that follow through is somewhere around 25%. And when someone's co-located and we can bring them in the room and say, this is Dr. Friedman, who I was telling you about, and I'd love for you to meet her, and then you can set something up. For us, that follow through rate was just over 75%. So we've been able, before the pandemic, but especially now, we've been able to help our patients. And as you know, it's a source of burnout for physicians, right? Handling all of this mental health, and it's helping our doctors as well.
And we had once in our office, we worked with a hospital system where they provided a social worker inside our office. So all we had to do was send them the cases and give them a soft handoff. It worked. I mean, her schedule was full. She had like 350, 400 patients quickly. But the hospital couldn't make it. They couldn't make it work. The hospitals, they couldn't do the billing, so they pulled the plug.
Yeah, we went from 1 psychologist to 3 in a matter of about 2 years, just for my practice alone.
Yeah.
And just one last question on that, and then I'll move on, is when you do the ADHD evaluations, do you use a psychologist on that, or do you just do the Vanderbilt and then move on?
We do a combination. I think most of our physicians are really trained in evaluations. We'll often do the evaluation. If it's something more complicated, we might then refer to one of our psychologists. We do a bit of both. But beyond the after hours, and the psychologists, just want to throw out there things that we were able to do very early on that really elevated our medical home was, as we were forming the hospitals, we're getting rid of lactation care, and we were able to hire our own lactation group to work for all of our patients. So we could say that every patient deserves lactation consultation, and provide that in a insurance credentialed way that wasn't a disincentive financially for mothers. And then we pretty quickly were able, as a multi-site, to achieve NCQA Level 3 PCMH certification.
Wow, that's great. Now, if I understand it correctly, you centralized all your billing.
That's correct.
For all your groups. Because you've been around for some months in this industry, that there's always the argument, should it be centralized, or should each individual legacy practice keep their billing? Why did you centralize it, and how did you go about doing that?
Yeah, I mean, I can't imagine, just for efficiencies and economies of scale and quality, why one would maintain billing. But what we did is we said, you know what, we don't need 12 different billers. It doesn't take 12 billers, or whether it was 24 or however many billers there were in total, to provide billing for the size of the group. So what we did is we took the best billers. Like we like to say, everybody got to keep their jobs when we came together in PediaTrust, but we reorganized. So we took some of our strongest billers and we put them together for centralized billing, which was not only a tremendous cost savings in terms of staff for the legacy practices, but we were able to really see really outstanding KPIs come out of our billing group. And at the time when we launched, we all went on Epics. It was a new practice management system for everyone as well. So some offices had individuals who just weren't going to be able to figure out the Epic billing on their own. And we even then started doing billing for other practices that were not a part of PediaTrust in our area, because so many individuals had billers that were struggling to figure it out. So not only did we centralize our billing, which, because remember, we had some practices join us who weren't necessarily doing their billing themselves. They were outsourcing billing and actually getting really not good care from their billing company, right? So they were doing tremendously. We were seeing KPIs. I mean, we continue to, and I'll give you an example of days in AR that were in single digits. It's almost unheard of. I was on PCC for 19 years. before we made this transition. And, if you look at MGMA or best practices or something like a, PCC or OP dashboard, you don't see single digit numbers with Blue Cross Blue Shield.
So I'm going to ask you just to step back a little bit, because not everybody that's listening to the podcast has the same level of experience and managerial experience. What's days in AR for somebody who doesn't know, and why is it important that the chairman or the practice owner know what that is on a week-to-week basis?
Yeah, so let's see, what would be the best way? So days in ARs is a number of days that your receivables are tied up, right? How long does it take you as a practice to get cash in your bank account from the insurance companies that are paying you would be, I think, the simplest way of thinking about it. And of course, we all need that cash in our bank to continue to keep our practices going, to cover our payrolls, to pay our rent, and of course, to pay ourselves as the owners for the work that we do, as well as all of our employees.
And a good days in AR for a primary care group would be?
So I haven't looked up MGMA, but I would tell you that it's probably, like, typically if you go and you read about this, you're going to see something in the 20s, low 20s up to 25 days. So, seeing something like 7 or 8 days, 9 days with Blue Cross Blue Shield, which in Illinois is, 50, 60% sometimes of your payer mix, is pretty fantastic.
And something awful in days in AR would be past 35.
I think once you get into the 30s, whoever is doing your billing, needs some education and some training.
And I often use the analogy that days in AR is like your ejection fraction. It's telling you the ability of your heart to pump the blood out and get back into your brain. What do you follow for, the return? What one KPI should a business owner or a managing director of a large group always know?
I think that's a long list. And I guess the best way to look at it is in various buckets, right? Because one wants to ensure that there's growth. So you want to look at things like new patients, right? So you want to look at the growth and think about sustainability of the practice. So you might look at new patients. You might look at visit numbers, what's happening with visit numbers. You might look at balance between well visits and sick visits, although those ratios have been a bit distorted depending on, COVID surges and in COVID. Then I think it's important to look at some of the financial piece, right? Like, what is your cost per encounter? What is the revenue that you're generating per encounter? Days in AR, which we just mentioned, net collection rate, which takes into consideration things like all of the money you're getting paid, not just.
So I'm going to interrupt you because you just said the one I was hoping you would say. You're only going to look at two. Net collection rates. What is the net collection rate, and what it should be? First, if your practice is all Medicaid, I will say it should be 100% because you have no patient collections.
Right.
But if your practice is not all Medicaid, what shows you that your front desk is doing a good job collecting copays, your billing is sending the claim to Blue Cross Blue Shield, and then sending the bill to the patient and collecting from the patient? What would be a net collection rate that would be acceptable to you?
I think that number needs to be in the high 90s. And right, so net collection, I'm going to make sure I'm getting this equation right, but it's your total current payment, and then that's divided by prior or previous month charges less, your current contracted adjustments. And so I think that's the math of the equation, but that number should be in the high 90s, but I really like to break it down. And I like to look actually at the separate components, because if you're very strong in some of those areas, but there's a problem in one of the others, you might miss it, right? So it's important, I still think, to be sure, like you said, Medicaid's 100%, but I think it's important to be sure when you're on multiple contracts with private payers that they're paying you at the contracted rate. We all know that that might not happen all of the time. I think it's important to look at AR by payer as well as patients and say what's going on at 120 days beyond or even 90 days and beyond. So I think looking at all of those components, and then look at copay collection rate. We have a scorecard, like some scorecards that we use as far as assessment of our managers in PediaTrust, and things like copay collection, signing up for auto pay, things that let us collect just on the front end, looking at patient due balances. I like to break that down too and look at all of the components. So yes, I agree with you that it's a good snapshot, but I would never just follow that number and not look at the components.
So you also said something that's also, I think, very important for people who are not in a big group is scorecards. If you don't make your expectation of what you need your managers, front desk employees to do, and you don't set that up front, they cannot succeed.
Right.
So that is a really great thing that you're doing there by setting up the expectation for your people to be successful.
Right.
Now,
these scorecards, well, who makes these scorecards for you guys?
So no. So we decide within our practice and our leadership, and in particular our CEO, but we decide, what are our strategic initiatives, particularly financial strategic initiatives. And then based on that, we set expectations, level of expectations for management. And of course, those expectations increase over time. So for example, it was our goal that 100% of our patients be on what we call auto pay. So we don't call it credit card on file. That is just kind of suspicious sounding to patients. It doesn't have a positive connotation. So we have auto pay. We have lots of patient portal utilities that, of course, if you could get your patients to do work that employees used to do for you, and you're not paying your patients to do the work, you free up your employees to do other things. So, or you reduce staff costs, which we all know is very high in pediatrics. So we establish these strategic goals, and then we create levels by which we think our managers should be achieving for whatever these goals are. And then they have monthly scorecards that show them how they're doing or progressing along the way to achieving that goal by the end of the year.
I would take that one level up, and I advise this to everybody. When you're hiring someone, doesn't matter if it's a physician, a front desk person, the person who's answering the phone, have that scorecard on the desk and say, this is what we're going to sit down and talk about in 6 weeks. You think you can do the job or not? Because these are going to be my expectations. I don't want to waste your time or my time knowing 6 weeks later that you can't do this. And some people will just look at the scorecard and walk away. But at least they know what you're expecting out of them, and they're not floundering when you meet with them in 6 weeks or 90 days then and say, well, I didn't know I was supposed to do that. I've rarely see that scorecard concept implemented in medicine, but that's very important. It drives success and accountability through your organization.
Absolutely.
I'm going to move on.
Susan, with all these contracts and bills and codes and Medicaid and commercial, who keeps track of all contracts and who negotiates them? How do you negotiate them? I mean, I presume you guys have a lot of leverage because you have a lot of people. And what is your experience with that?
We do and we don't, right? We're big for pediatrics, but we're still small when it comes to the insurance companies. So our professional CEO certainly does contract negotiations for us, but we are also part of local IPA. So we participate in other organizations in our geography where we have some of those contractual agreements. I will tell you that the plans that we carry independently, we
Hello?
I'm here. Hello?
Yeah,
Herb?
I'm here. Yeah, I'm here.
I think she has a hiccup.
All right, hopefully she'll come back.
Yeah. Technology never fails to us, it always fails. Well, she's probably telling us about how they go and they leverage the quality first. I mean, this is what I do. You leverage that you do good things, good quality first, And then you leverage, you have a lot of patients, and you have a lot of physicians, and a lot of places, and it looks cool, and everybody wants to code to you. So that's how we put it together. Looks like she bounced off. She'll be back.
She'll be back in a minute.
She'll be back. Yeah. So I mean, that's what you do about leverage with insurance countries, because there's always the discussion of, how can an independent practice negotiate? Nobody wants to negotiate with you. They don't want to pay attention. You know what? I found that
that's not true.
That's not true. But you have to go to, most practices, they'll just, stamp their hand on the table and say, I demand more money. The insurance companies, they won't give you more money just because you're good old Dr. Herb.
Right.
Herb proves to me why we should give you more money. If you prove to me why we should give you more money.
And if you appeal to fairness, if you show them my one PPO that accounts for 40% of my practice is paying me, 150% of Medicare and the 99213, there she's back.
Mm-hmm. Yeah, she's back. Yeah. So, but you have to prove to them first that you do. So back to do good quality medicine.
Internet went out here. I don't know what happened. I'm on my hotspot.
We were talking. Yeah, we were explaining about contract negotiations and how you should always do good quality medicine first, then the money follows. Most practices, independent ones, they feel, unfortunately, that just because I'm a doctor, I am entitled or I should be given. Well, I wish it was like that, but there's practices and practices. I mean, a practice that's totally technological has everything, good quality metrics and patient access to care. Why should they get the same as the person that's, just on paper and they're still writing prescriptions by hand? I mean, that guy should be less, I guess. Yeah, so let's continue.
So I'm going to pivot a little bit, and I know there's a lot of KPIs that your group must follow for quality, but what is one or two of them that you're following right now that you think are important and that you're trying to improve? And how does that inform the negotiation with the payers?
That's a really good question. We are not in the process right now of negotiating any one particular contract with payers. I will tell you that I think our PCMH certification and continuing with that is important to us. So we are continuing to engage in that process. That does bring quality. It's very hard right now to look at value in the sense of what we're spending or what the cost is, because we're constantly COVID testing and we're using, some molecular tests that are expensive, and at least for now, the payers are paying. So I think the cost of care is a little artificially elevated, right? That's why in all of our practices, we're seeing very different numbers for charges and for payments than we typically see. I don't think there is one thing to follow. I think we have to look at growth. I think we look at a lot patient recall for well visits, because I'm not sure how it is where the two of you practice, but it's very important to see a patient for well care, for them to be attributed to the physician for our ACOs. And so I would say, if anything, that's probably one that we're absolutely following. But I think the standard KPIs that we might follow are very hard to look at right now in COVID, as far as numbers and spend and value.
Now, you love technology.
I do.
Have you been quoted as having said that?
Yeah.
And so when you're recalling patients, I'm sure you're doing it through text first.
So we use a communication tool. It literally has a direct link of information right out of our EMR reports straight to a communication to patients. So absolutely, our patients are getting a text message from us, and it's a personalized message with a call to action, right? And that call to action is, your doctor wants to see you. We miss you, and it's time for your checkup. And so that's how we start, but some people need phone calls. Not every patient wants to interact with us that way, but most do.
And does your text allow the ability to send a video?
It probably does, but we haven't done that yet.
Okay.
That's an interesting idea. We do also, we have one of our, when I was talking about the scorecards before, we had a goal a long time ago of 100% sign up for patient portal. We call that My Chart and Epic. And so we also are able to message our patients that way. But before we had that, we got used to using a great communication tool.
Yeah, the reason I ask you that is because the people that sell homes, the salespeople really know what engages people, because that's all they do all the time. And they know that if you send a text with a video, it gets umpteen more clicks than if you just send a text message. There's nothing like seeing that the face of your doctor on a 1-minute video saying, it's time for you to come in. I haven't seen you this year. For people to go like, oh, yes, got to do that. Got to pay attention to this text. And text is umpteen times more than email because we all live on our cell phones and the text message is first thing. Now, you also use a product that I'm very curious about called Simply Speak. And it is a dictation to EMR interface. Is that correct?
Yeah, so what it is we accessed it through a Chrome extension. And this was something I was introduced to in its first startup form through McConnors. We were really early adopters of telemedicine. We had started telemedicine with Anytime Pediatrics prior to COVID. We were already using telemed. And so we was introduced to this. It's essentially a virtual scribe, but it relies on AI. And so what happens is your visit is recorded or transcribed, and then from that transcription, a note in the template that the physician prefers, a note is created. And then that note, because this is an extension, so it layers onto our instance of Epic, it is just then copied and pasted right into the EMR. So obviously quite perfect in a pandemic when we were trying to limit the number of people in the rooms. It's also it doesn't involve training. There's no training to get an individual to write the note the way someone wants it. And it's a good tool. And it's not, I don't necessarily use it for every visit, but we've made it accessible to our doctors. So it can be used in telemed, but it can also be used just by recording off the mic of the laptop for in-office visits.
And do you get a lot of adoption from your doctors? Do they like it, or some do, some don't?
It's really variable. I mean, as you can imagine, if you bring, 70 or so pediatricians together, not everyone likes technology, certainly not as much as I do. And, many don't like it at all. So my goal is to make these things accessible to those who want to use it. And for those who don't, that's the nature of our decentralized structure. You choose what you do day to day in your own office. Our next big tech launch is we have a physician who started using point of care ultrasound, or POCUS as we like to call it. And we are building that program. We have several of us who are getting some training through a course this fall, and we're going to try to build a great outpatient primary care pediatric ultrasound program throughout PediaTrust. So,
oh wow,
things like not having to send kids for chest X-rays, being able to identify some simple fractures. There's so many abscesses that we drain. There are a lot of use cases, and we hope to build that for pediatrics.
So when
as an adjunct, not replacement for higher level of care that we're not trained for.
So when you do that, when you identify like a Colles fracture, will you be able to splinter in your office?
Yeah, ideally we'll start to figure out what we can identify and what we can care for, and that's the more you can do in the medical home, I think the higher the quality is of the care that you provide, and patients love it, right? They don't want to be traveling all over town to get their care.
Plus, I think, I don't know this, we'll have to ask Russ Livy, but my best guess is that when you're learning new things as a physician and you're doing good for your patients, it keeps you engaged and somehow prevents some of the burnout.
Yeah.
You know,
I agree. I also think it will be a tool for us to attract doctors who want to work for us. I have 3 kids, and my middle child is in her 3rd year of medical school. But when she started her clinical rotations a year and a half in, they were all provided a butterfly, which is one of the small point of care ultrasound devices. So, this is something physicians are being trained to use.
how very cool. And I'm sure you have many dashboards that you look at every day to see how the practice is doing its, in general.
Yeah. So I don't look every day, but I do look often. And for the most part, unless I'm concerned, like I get an indicator that there might be a problem on a day-to-day basis, we have a whole suite of reports that we push out every month. And that's really what I look at. I look for trends every week or so. A lot of this is accessible in our EMR, but I do look closely across the whole company on a monthly basis.
Yes. It's very important to look. Sometimes if you look every quarter, it's too late to fix the problem.
Yeah, I mean, a real biggie is distribution of coding. So when our practices take on new doctors, we have some training that comes from within, but I will periodically, because I know there are those who just have some challenges, even with the new E&M coding, and I'll go through and just say, hey, give a little reminder to Dr. So-and-so, it's their coding looks like it's off. So
very good. And what do you think is the biggest problem you see in pediatric medicine that needs to be resolved?
That is a very good question. And I'm always like, there's more than one fish in the sea kind of person. So I don't know that I could say this is the biggest problem. But one of the things I've thought about, I think for years as a pediatrician, is that our patients and our work is undervalued. It's undervalued in so many ways, but certainly by payers. George, you were alluding to this earlier. And it really came out in the pandemic, right? So a number of examples. CDC guidance early on. What do you do? How long do you stay home if you have COVID? There was no specific guidance to say, well, it's not really 10 days if you have a child, because you can't send your 3-year-old to their room for 10 days and say, hey, you're on your own, right? It was 10 days from the last day you took care of your child with COVID. We look at payers and we say, okay, what does the radiologist get for reading a chest x-ray where they tell the pediatrician there may or may not be a pneumonia, right? Like the non-read that we're all used to getting. Yet you spoke to them during the night when the child spiked a high fever and had a little respiratory distress. You saw them in the office the next day. You planned a way to make a diagnosis. You prescribed, and then you followed up with them the next day, right? Just to make sure the child was doing okay. That is not valued the same, as far as the way our work is paid as, say, someone who reads an x-ray. So I think there are a number of examples where insurances, I think, people, like we've all heard it before, children are somewhere around 24-25% of the population, but they're 100% of our future, right? We hear that all the time. But payers, what they cover, we don't see that. How many times has a pediatrician had to fight for care for a child with developmental disability? Yet an 85-year-old or older adult who's had a stroke and needs some care for rehabilitation, not an issue. So I think, and when our patients aren't valued as much, maybe we aren't valued as much in our work. We value ourselves, but the outside looking in. And I think when that happens, sometimes pediatricians make decisions or do things in a way where they then diminish their own value to those around them or the outside looking in. So I think we need to turn that around. I think that's why we're all advocates as pediatricians. We have to be. But I would love to see the work that we do, the value of the work that we do, because it really is everyone's future, be viewed differently. I think it's a problem.
Yeah, that's.
I think we as pediatricians don't value ourselves. I think we get to the point where we get so good at our job. It's just an ear infection. It's just a shot. The outside world is going to think it's just a shot and it's just an ear infection. It's not complicated. So if you don't believe in yourself, and I don't believe in myself. Why should we?
I agree with you to a certain extent, but I think those who do well see it a little differently, and they do value their work, and they do expect, right, to receive recognition for that value in different ways. But just for example, there's some pediatricians who don't think of themselves as specialists even. We are specialists as pediatricians. We are expert in children. We are specialists in children and adolescents and young adults. But there's so many people who say, well, you know, I'm not a specialist, yet they are.
That's right. Yes, that's right. It's a very deep-founded problem in American society where we shifted all the money to the elderly for healthcare, and because they vote and they organize, and
Right.
we value expensive treatments, but we say preventive medicine is great, but we don't really put any money behind it. And that's one of the fears I have right now, is that there's so much mental illness, anxiety, depression that has come to the top after COVID, and the money's being thrown at treatments. We're repeating the mistakes of Medicare and Medicaid, where we create these huge industrial complexes that treat patients, but we never invest sufficient amount in prevention. And any economist, whether in the health business or not, will tell you every dollar you spend in prevention in a child will go 20 to 100 fold into the pocket of society through the lifespan of that child. And so there is absolutely no reason why we're not spending more in preventive care, early detection, fighting obesity, anxiety, depression, asthma in young children, so that we have a healthy workforce into the future. But that's my soapbox. What have I not asked you that you think our audience would benefit from knowing from someone who's managing 75 pediatricians and doing great work out in Chicago?
You know, I think there are a lot of benefits to practicing in the structure that we practice in. And sometimes there's so many, it's so hard to list. But to be, and we've seen the benefits of being in this structure play out over and over again in PediaTrust. So whether it's savings for economies of scale, like the malpractice that we pay for, whether it's improved contracting, whether it's things like we can share staff. Our staff are all employees of, you know, we're a single tax ID. They are all employees of PediaTrust, even if they're assigned to different locations. So if I have a day where an emergency comes up and I don't have someone to work at my front desk, there are 11 other practices who can work a little short and send someone over. If I am looking for help with something to do with a patient, we have a communication tool where I can just post my question, and I have nearly 80 physicians who can give me an answer. We have this brain trust of individuals with different strengths within pediatrics that we can call on, and we can learn from one another, right? Like so many pediatricians, they never leave their own office to see what does another waiting room look like? What is a workflow? What is a process in someone else's office? And so we get to learn from so many different individuals and really come to best practices in an easy way that might not be possible if one is just in their own independent practice. So I just think every day there are more advantages, you know, and a perfect example for us was things like in COVID, right? Our offices were being overwhelmed by the need to test that we couldn't even figure out how to get all the patients in that we needed to see. So we were able to come together and say, let's just create a testing site. Let's put a nurse there. Let's send some of the analyzers there and let all the patients go there to get the tests that they need on a day-to-day basis. And let's keep them away from the offices so we can do the other work we want to be doing. Or in my own office where we had, you know, just this tragic, literally tragic mass shooting at the doorstep of our office outside our door on July 4th, we were able to, by the next morning, be up and running in space that was provided to us through another office nearby, and to continue to do that for almost a month until the repairs were done in our own office. So things like that, you can't even imagine, right? It gives a whole new element to disaster preparedness, to learning, to providing care for patients, and certainly for economic advantages.
So we all felt your pain during that shooting, and we were praying for you and your work family, your own family, and your patients. And before we started taping, you said you guys are doing well, which is great to hear. But that spillover trauma or that moral injury has been very hard, and we feel for you, and we wish your community and your families the best.
Thank you. Thank you for that.
Well, this has been a wonderful time with George out in Italy, you in Chicago. And we have some really exciting things coming forward, right? In October, we're going to have a panel discussion how to integrating mental health into pediatric practices. You're going to be part of that with Carrie and Russ, Scott, and I'm really looking forward to seeing you all on that panel. Is there anything else you want to say to our audience?
No, I don't think so. I just so appreciate the opportunity to have this conversation with both of you.
Well,
And enjoy looking at what's behind you, George. It's gorgeous.
I'll go. And the whole purpose of this podcast is just to get doctors to talk about stuff, without anything. Just whatever it is, shoot from the hip. We lost touch of that with all these computers and social media and metrics and MBAs and hospitals. It's like nobody talks to anybody anymore. So it's just nice to talk and elevate people like you that did great things, because do you know what? The young kids, the young generation of doctors, they have no idea what Dr. Sirota did and the great things she did. They're all just a bunch of worker bees, and they're happy with that. We got to teach them that that's not the only way.
Well, thank you so much for your time. Always the greatest gift you can give another human is your time.
Yeah, thank you, Susan.
So thank you so much.
Thank you both.
We'll see you very soon. Please stay
See you
safe.
soon. Take care.
Bye.
Bye-bye.
Bye-bye.